So now we'll move to two additional areas that the group collectively focused on. One is this notion of what were the attributes and care and subfeatures of care models that have been shown to be effective in moving one or more of the triple aim variables. And then secondly, we want to just provoke your thinking about how one might go about, whether one was leading a healthcare organization or one was a care manager, beginning to match program characteristics with individual patients. Maybe just begin by saying, this is reflecting on this, flying in last night, I was left with sort of two dominant feelings, and I don't know, how you will feel as the day progresses, and specifically after you listen to the results of this part of the committee's work. But on the one hand, I felt optimistic because if you think about what's evolved in America over the last really 100 years, there has been a steady evolution. It wasn't that long ago that there were 5 boxes that defined America's care models in most modern nations. It was either you could either end up in the office of a surgeon, a medical doctor, or an alienist, or you can end up in a hospital, general surgical ward or a hospital general medical ward, and maybe an OB ward, but that was it. And then think about what's happened over the last 100 years as medical knowledge and healthcare delivery science has begun to advance. We've made there's been a lot of evolution and customization, most of it with very good results. So that's the basis for optimism. Let me move now into specifically what our subgroup where we arrived, and first of all say that in the tradition of the national academies, we relied heavily on where we thought the evidence was in terms of the broad characteristics and some of the sub-characteristics that are associated with better results. And we reviewed, we heard from a lot of people, and they pointed us in their testimony into a lot of good literature. But we did probably disproportionately focus on prior efforts to synthesize the evidence, and particularly the evidence distilled by both McCarthy and Bolt. And here's the bibliography, which is for your information. And here's where we landed. As we began to think about it, we realized we were looking at different levels of granularity, and so that's how we've organized this. If you quickly screen this, you'll see that we identified 3 broad categories of what we call successful care models. We identified 7 thematic overlaps or attributes that these models generally shared. And I think I will spare you, reading them, but you can intuitively sense what they are. And then further, there were issues having to do with more granular implementation tactics that we also called out 9 of these. And then last, we noticed that in terms of a really fine-grained understanding of this, that there were certain what we categorize as operational practices and tools that also cut across the successful care model. So that's how we've pulled together the evidence we reviewed into what we think is a rememberable 4 category approach to thinking about how one might characterize a given care model for high need, high cost patient. This is now we'll move into the most intriguing and I'll call it humility-inducing phase, which is to essentially try to go from a set of care models, each of which has a certain provenance in terms of we know that they didn't get into the mix unless in some relative to some local baseline there was movement of 1 or more, and often 2 of the triple aim measures. But how does one go from that? Because each of those has a particular set of patient inclusion criteria to the diversity of patients that a healthcare organization or an individual care team might face. This is the crosswalk phase. and we picked 16 care models, and we did this really illustratively to sort of provoke thinking. We think there's a lot more to do, and I'll talk about that when I close. Let's see. So just to give you a notion of how this might work, here across the top we've arrayed the patient taxonomy groups that Melinda just walked through, and then on the left side we've picked some representative programs that fit our criteria for evidence of movement on the AAA measures. And one can, even if one does this very intuitively, one can begin to see areas of overlap and match. And since nobody wants to really go through all these cells, I thought we'd sort of drill down a little bit. The programs we selected are based on available evidence, obviously, and in terms of saying, well, since we wanted to move the needle both on cost and quality, and also obviously patient experience per the prior panel, how well did these programs do that sort of surfaced as the winners, or the ones we wanted to highlight? And as you can see, they varied. There weren't too many that actually moved the needle on all three of the AAA measures, but we did pretty well when we lowered the cut point to at least 2 out of 3, as you can see. So let's now take a closer look so you can get more of a sense of what it might be to be a healthcare system leader or a clinical team member, and try to match what we uncovered to a group or a single high-cost, high-need patient. And so here's just a home in, and here, so frail elderly, what were the programs that we unearthed that were effective, that favorably impacted health and well-being, measures of utilization, or cost, net of the cost of the program itself, which is obviously an important caveat. As you can see, for frail elderly, we had a pretty good range of interventions that moved, health and well-being and cost. I think a lot of this research, preceded the growing importance of patient experience. So we haven't rated that. It often wasn't present in some of the evaluations. But had we done it, some of these programs would have also moved the needle on patient experience. And then another of our categories, frail elderly, subcategories, frail elderly with behavioral condition and/or social complexity. There were a different set of programs were effective, and these included some that have been prominent in IOM and NAM presentations previously, including at University of Washington and others. Now, most of what we looked at were what I'll call sort of examples that come out of the annals of health services research, but we also thought it would be useful to just expose you to an example from the real world, and it didn't come out of setting up a health services research design, but rather this is a real world program that for which the program, even though it isn't published yet, there is evidence of effect. But we thought it might give you kind of more of a tangible sense of how these work. This is a population health approach where essentially it applies to everybody being served by the Denver Health delivery system. It stratifies patients and matches a variety of programs that they can bring to bear, that they do their best to tailor to patient needs. And the stratification incorporates predictive modeling combined with a clinician assessment. And this gets at one of the points that Melinda made, is that the data we've had to work with so far has primarily come out of health insurance claims, and we're obviously on the brink of having made major progress thanks to leaders like David Blumenthal in about, I think we're probably about 5 years away, depending on how things go politically with data exchange, to having a much richer data set that can begin to get at some of the variables that led to, that would have allowed Melinda to even further and do a more refined segmentation. Right now, we don't have any representation in health insurance database that might, for example, represent the the efficacy of the in-home family member or caregiver. Nothing remotely approaching that, even though that is essential to even a medically based categorization. And what's nice about this is they used a conventional, off-the-shelf, commercial approach to segmenting. They used CRGs. So, here's how Denver Health, in a real-world environment, begins to take this information and, in this case, trifurcate, the entire population they manage into these. Actually, I don't know the word for quadricate. Okay. Into 4 categories, and yeah, and this is I mean, this also gets at Janet's question of, well, how big a catchment area would you have to pull patients into if you wanted to begin to really finely match patient characteristics to care delivery model characteristics. But here in a city the size of Denver, and again focused on the population being served by the Denver Health, which is a public healthcare delivery system. Here was an intuitive frontline clinician leader's thoughts on how you go about creating 4 care models that begin to match this high need, high cost population. Obviously, tier 1, that's it. That's everybody that's not high cost, high need programs. And there, if you just glance across it, you begin to see how we might, as a nation, actually begin to pay for these intensified programs for patients with high needs, because you can begin to see, what many advanced delivery systems have discovered, which is, gee, a lot of the time we're using up with clinicians now are low value uses of clinician time, like chronic follow-up visits following for patients who are stable with a chronic disease, moving some of that onto a telephonic and or email platform. And then we move into sort of tier 1, the next level of challenge, which are, I won't read through this, but you can intuitively sense why that might have involved a less complicated and expensive solution than what occurs as you move further to the right, and the level of need and cost risk begins to rise. I thought I'd just, one of the things you'll note is that as you move to the right, as David Labby has taught us, for anybody who's been attending these meetings, and as we heard in the prior presentation, one begins to have to intervene much more intensively with respect to behavioral and social needs. And you can see in level 3, we're talking about consultants to the team and clinical social workers, and then as you get further out to the right in terms of need and risk and cost risk, you begin to evolve this need for specialization. For example, a clinic that wouldn't simply serve all high needs patients, a high intensity team, so-called AICU style model, but you need to begin to differentiate it by age. So one size fits. You could do better if you have enough children in your catchment area to begin to customize at that level. So what were some of the high-level takeaways that our subcommittee wanted to leave you with? Well, first of all, the good news is we're a point in evolution in our health services research evidence base, that there are a number of care models for high needs that bring along with them good evidence of impact on things that matter to the patients and to society more broadly. Secondly, across successful care models, there seems to be a pretty broad consensus on attributes that can make a difference in patients' either health trajectory or health spending trajectories. And we also, obviously think, as you saw intuitively, we think there would be a basis for using just intuitive human brain power to begin to match some of these care models to a given patient or to a group of patients if you are leader of a healthcare organization attempting to segment and customize your care to a population. And last but not least, we think that a tool like this, even if at the beginning it's implied very intuitively, would enable people who run healthcare organizations to begin to move along this, what has been really 100-year customization of care, of beginning to match care delivery characteristics to particular patient needs. So I thought I'd just close with some, I want to provoke your thinking, and so I'm going to move from the optimism phase that I opened with, which is, this observation that as American healthcare has begun to, over 100 years, begin to get better customized to patient needs, and we're no longer stuck with 5 cells in terms of where you end up for your care. There are some, you review this and think about the committee's work, and you begin to, there's some intriguing challenges at the frontier of knowledge that just invite the kind of pioneering community work that we learned about through this process, and/or imaginative health services researchers to begin to illuminate. The first and foremost is we do have to acknowledge that this is not a recent quest. I think I went back, at least in the articles that I've collected over the years. I think it was in 1980, a doctoral student at Brandeis, Mary Henderson, published an article, and she said, gee, people are now realizing that there's a so-called power law distribution in healthcare spending. There's a small group of people that spend most of the money. But when you begin to look at what was in the 80s, the answer to the question, which is add a nurse care manager, who will make phone calls and occasionally visit the patient, she said, I'm sorry, everybody, but the evidence suggests that it only is cost-effective and significantly effective for patients with severe mental health problems, period. For the rest, it was not, the thesis that if you could simply begin to intensify resources, that you would both save money and improve quality was not proven. It was ignored. I think it stimulated a lot more innovation. Secondly, I see Mark Miller here. I remember the day that we, after a lot of waiting, MedPAC received, Randy Brown and others, kind of summary of all these pilot projects that Stu Gutterman had kind of launched between 2000 and 2010. And I remember what it was like back then. Early in the Bush administration, people saw this power curve distribution and said, Medicare, let me at it. We're in the phase where entrepreneurs like us can come in and just show you what we can do. And the Bush administration took a lot of them up on it. There were, I think, if you count all of the demos and pilot projects, there probably were over 100. But what Randy Brown's, and CMS's evaluations of them kept showing is that fewer than 5% of them actually moved the needle across both clinical outcome and lowering cost of care net of the cost of the intervention. So that's we have to realize that is a challenge to this work. Intensification of care is expensive. And one of our recent CMS administrators used a word that still haunts me. He talked about healthcare's unintended confiscation of resources that society might use other ways. So when we intensify and make care more expensive, we need to keep the focus, as this committee has, on does it make a big difference in health at a similar cost, or does it actually lower per capita spending and thus free up money not only for extending health care benefits, but also other things that society wants to invest in. A few other just high points, and then I'll turn it over to you. We learned that most of the patients who are in the high cost group are transient, and the windows of opportunity to impact that trajectory effectively and cost effectively are often limited, and the information we have on which to know when those windows of opportunity to intervene effectively and cost effectively is often extremely limited, at least until we begin to solve these data exchange problems. We know that a lot of the variables that were used as inclusion criteria in the study were characterized dichotomously, old, not old. but most of these variables are in fact, continuous. And we begin to move forward, we need to think about ways of approaching this that begin to allow us to tame, what will inevitably be, an enriched set of variables that will characterize people across the full continuum, and in many cases, variables that we don't currently measure, courtesy of actually some other work recently led by NAM to begin to routinely populate EHRs with a certain set of psychosocial variables. Last but not least, some of our presenters. Actually, I think what I'm going to do is, rather than belabor this, I just want to stop there and invite your discussion, because I think I've probably provoked you enough, and the collective knowledge here is much greater than mine individually. So please, and I'll sit down so both Melinda and I can address questions.